be here this evening with you all. I'd like to thank the chairperson, the speakers, and also the panel today for being here and putting this together. Incredibly excited to able to share a little bit about Paxman and why we do what we do, but more importantly, hearing from Dr. Bajpai and Dr. Vora today and about their experiences in India. So India is an incredibly important market to us, and we're excited to do more. And hopefully in the coming months, we'll have more opportunity to work with you all. So let me get started then. So why is scalp cooling so important? So really it is one of the most feared side effects for patients undergoing chemotherapy treatment. In fact, about 75% of patients rank it one of the most feared side effects. It's often considered one of the most traumatic side effects of the treatment and can even lead to social isolation. And it doesn't just affect the patient, it actually affects the patient's friends, family, work, colleagues. In some patients, it will affect self-image more than breast surgery. And then there are a number of patients who will actually reject chemotherapy because of it. We also see in a number of patients who have a high dose or a cumulative dose of over 400 milligrams per meter squared, a persistent level of alopecia. And that's in about 10% of patients. This toxicity can be stopped with scalp cooling. So why we do what we do specifically at Paxman? So this all started in the 90s when actually my mum, my late mum, was diagnosed with breast cancer in the 90s. She had late stage cancer, she was only young, and she had 4 young children. And my mum didn't want to lose her hair. She didn't want to look like that cancer patient. So they actually offered my mum something called scalp cooling or cold caps all those years ago. But unfortunately it was unsuccessful for my mum. That was the first time she was really affected by her disease and her poor prognosis. So seeing that distress that it had on all of us, not just my mum, my father started to look at, well, why didn't it work? And what can we do to help patients in the future? So we've spent the last 20 years developing scalp cooling technology, but more importantly, making sure it's accessible globally for patients to have that choice, to make that decision about scalp cooling. We lost my mum 20 years ago, so we're very passionate about why we do this. So where are we in the world? As I said, we've been doing it for some time now. So India, we've been working in that market for a number of years. In fact, we were just saying that Dr. Vora and I met about 3 and a bit years ago. But we manufacture everything in the United Kingdom, which is where we're based, and it's a British manufactured good. We've got about 3,500 of these scalp coolers worldwide now. If you visit us in England, and I'm sure many of you might have trained in the UK or at least had some working experience in the UK, we're in 97% of all the National Health Service hospitals and the private sector. So all the big names, the Clatterbridge, the Christie, all on Harley Street, the big private groups also all offer scalp cooling with our device. We've also started distributing internationally for the last 10 years. We're in about 50 markets worldwide in some of the best cancer centres known. So really starting to become a standard of care in many countries. In terms of the US, which is probably our highest growth market, we've got 330 locations alone in this market since we got FDA approval 3 years ago. So really moving towards standard of care, which is incredibly important. Some of the names that you'll know in the US are the likes of Dana-Farber, Mayo, Mass General, Memorial Sloan Kettering, Fred Hutch at Seattle Cancer Care Alliance, MD Anderson. In fact, I think we're in the top 11 cancer centres in the United States, along with many others. So a little bit about the system. So our scalp coolers come in a single model or a double model, and I'll show you a picture of the double model shortly. And what we do is we pump a liquid coolant around a soft silicone cooling cap that's worn for the patient 30 minutes before the chemotherapy, so during antiemetics, throughout the chemotherapy treatment, and then normally about 90 minutes to 2 hours after treatment. So minimal nursing supervision is needed in that last 90 minutes, and the patient finds it generally well comfortable, can disconnect, go to the bathroom, etc. They can read a book. Many of our patients also will just fall asleep. The coldest part is that first 10 to 15 minutes when the cooler is first switched on. It's very, very simple to use, and we've designed that with the nurse in mind. What we want to try and ensure is that it is easy to use and it minimises the impact on your infusion centres as much as possible. So we have a PSCS1, which treats one patient at once, and a PSCS2, which you can see here, which can treat two patients at once. So you can have a patient sat by the other patient and treat them simultaneously. So much easier for a larger or busy clinic. So how does scalp cooling work? So it's the only method that we can use to actually reduce or prevent chemotherapy-induced alopecia. So chemotherapy works, as you all know more than I do, damaging the mitotic and metabolic processes in cancer cells. So what we do is we cool to protect. By cooling to around 18 degrees Celsius, we induce vasoconstriction. So we restrict the blood flow and the amount of chemotherapy that gets to the hair cells. Very, very simple. What we also see is that these lower temperatures is a drop in metabolic rates. So this drop in metabolic rate reduces cell division, therefore less targeted effect of the chemotherapy. More recently, we've developed our own in vitro cell culture methods, where we actually infuse different chemotherapies into the hair cells or the skin cells, and then look at those cells at different temperatures to check cell viability. What we have seen is that less drug diffuses through the cell membrane at lower temperatures, both actively and passively. So the more we learn about these types of mechanisms, the better we can make scalp cooling in the future. So there's lots of clinical data available, and as you know, one fantastic clinical paper, which I'll touch on very briefly, by Dr. Bajpai at the Tata Memorial Hospital. But we've got now well over 8,000 study subjects within all our data globally, so different ethnicities, different hair types, etc. What we tend to see is most are designed in a sort of observational way with either historical controls or even smaller control groups. But we do have a couple of randomized control trials and then some other smaller registries. The largest registry we have has got around 7,000 subjects in it. What we tend to see on average is that 50% of our patients are successful, or 50 to 60% of our patients are successful, should I say, across a wide range of chemotherapy types, but also solid tumor types. Whereas we don't see patients who don't have scalp cooling be successful. So a very, very clear benefit. Here we have a randomized control trial. This is the trial we actually got our FDA clearance from. And this was put together with the Baylor College of Medicine, Memorial Sloan Kettering, US Oncology Research, and Cleveland Clinic, all very key centers in the US. What we saw at the end was that the primary interim analysis, is that 50.5% of our patients were successful versus no patients in the control arm. A clear superiority, which actually led us to submit to the FDA. We continued that study to 180 patients. And what we saw after the 180 patients was that 53.1% of patients were successful versus no patients in the control arm. Again, very, very clear benefit of scalp cooling. What was interesting though, is that the anthracyclines versus taxanes was different, as we've learned already, but only 16% of patients initially were successful with anthracyclines, but after time that rose to 24%. So what we've taken away from that study is that there's always a learning curve. So I'm sure Dr. Bajpai and Dr. Vora felt initially that actually their results got better over time when the nursing teams got more comfortable with the use of the device. And that's really important, why we invest in training and really encourage to educate the patients properly too. Scalp metastases has historically been a concern. This is a study which is looking at scalp metastases with a 5-year follow-up. But of course, we've not seen any concerns as yet. And most patients rated this reasonably comfortable. In terms of side effects from this study, we see headache and nausea as the most prevalent. However, always grades 1 or 2 and always transient. So easily managed with light pain relief or even Ativan in certain cases, and it always disappears. We do see some sinus pain, pruritus, dry skin, etc., jaw pain, and we've seen some light skin damage when a headband or a protector has not been used, which we always recommend in our IFU. This is a German study. I think it's got to be that German efficiency that's coming out to some extent. So what they did is they actually reviewed this data compared to our US data, and said that the nurses were well experienced already and well trained with the device, which helped. They understood how important cap fitting was, and also that they followed hair care measures. So very key to understand this. They use anthracyclines and taxanes, but in Europe we use epirubicin over adriamycin. Just looking at the actual overall results, about 20% of patients didn't have really any hair loss, and 32% of patients had about less than 30% hair loss. So some really strong evidence here. This is a Dutch study, and I really bring this to light because they've got over 7,000 patients in it now. And on average, we see that 56% of patients are successful across a wide range of drug types, as you can see in the table below. What's important to understand is that we do see variations from location to location. And I really do think that is about how well it's used. And again, that's really important that we really push for training in our hospitals, in our centres. One important thing to think here as well is it's across a wide range of solid tumour cancers. A Japanese study, I'm not going to go into masses of detail on this, but this is one of the first studies, although Dr. Bajpai has also proven this, which is wonderful, is that we see when patients have scalp cooling, even when they're not successful, they get much stronger and faster regrowth. A really important discussion to have with your patients. If you look at the images here, 2 of the top patients have had scalp cooling, and the control arm do not have scalp cooling. You look at 4 weeks and 8 weeks and 12 weeks after chemotherapy, the rate of regrowth is incredibly strong. What was interesting in this particular study is that the efficacy overall was relatively low at about 30%, but we believe that 30% may well be related to the head shape of the Japanese. So in Japan, what we've done is develop a slightly different cap, which we are now also using in India, which we believe is a better fitting cap for different populations and ethnicities. And we'll continue to work on the cap to make it even better in the future. Another Japanese study which really shows when we do use the product correctly, unlike the previous Japanese study, we get much better efficacy, more in line with our results in Europe and the results we've seen in India. What's interesting here though, and I bring it to your attention, is that they get better results with anthracyclines than taxanes, which is different than what we see in America and in Europe. More work needs to be done there to see if that's anything to do with ethnicity or race, but we will understand in the future what that might mean. It may be just this particular study. And then very, very briefly, because I believe Dr. Bajpai will be talking about this particular study, but this was a fantastic randomized control trial looking at scalp cooling at the Tata Memorial Hospital. And what we saw again is on average around 56% of patients or 55% of patients were successful with scalp cooling. And that's with anthracyclines and taxanes. What's interesting is we saw that if we provided the taxane first, followed by the anthracycline, we got far superior results, which has also been seen anecdotally, but this was the first study to prove it, which was fantastic. And where we can use the taxane before the anthracycline, we should really consider that in the right setting. What we've also seen, again, is that faster and quicker regrowth, which is excellent. I touched on this earlier, but persistent alopecia. So patients who have a cumulative dose of 400 milligrams per meter squared have seen around 10% persistent alopecia. So that's grade 2 alopecia for over 12 months, which is very concerning for patients. What we see if we scalp cool, we don't see any persistent chemotherapy-induced alopecia. Scalp metastases has been long debated by many around the world, but what we do see from the retrospective analysis that has been carried out in large meta-analyses, that actually no patients with or without scalp cooling see a heightened or an increased level of scalp metastases as a primary occurrence, and ultimately overall survival. In the United States, it's now NCCN recommended as a category 2A option for patients with invasive breast cancer, ovarian cancer, fallopian tube cancer, and peritoneal cancer. So I think a really important step towards standard of care. We also know that very soon the scalp cooling will also be included on the Australian breast cancer guidelines and other solid tumour guidelines too. And we'll continue to work with global guidelines to make sure this is standard of practice. Patient support is really important, and I think we need to probably do more in India, and we will support our brilliant partner Access Devices in doing this, but really making sure that patient has the right support. We've just launched our coldcap.com new website, which is specifically for the patient. It has a great decision tool on there, which is being developed using the data from the Dutch study, the Dutch registry with over 7,000 patients in it. And that actually allows the patient to go online, put in their drug regimen, and understand what levels of efficacy they get. So they can make a really informed decision on whether scalp cooling is right for them or not. We also allow us to put where we are in the world and whether or not scalp cooling is offered at your particular institute. So a good marketing tool as well. We have a hair care website, which is fantastic. Again, hair care is really important for good efficacy. So we really urge your patients to go and look at our materials. What we're wanting to make sure as well is that we're more inclusive and more diverse in the people that are on our websites. So it's appealing to all ethnicities around the world, which again is really important, especially when we're talking about hair types, etc., and European versus Asian hair, etc. And again, more patient education, more patient leaflets. Hopefully we can work with you all to develop the right materials going forward, which will be in your hospitals. I personally am very committed to research, and what I want to get to a place is that it's not 50 to 60% of patients that are successful with our device, but it's 100% success. Now, we may never get there, but that's my real sort of goal and ambition. What we're working on at our Paxman Research and Innovation Centre is the future of scalp cooling. So that will include the perfect fitting cap. So we're looking at 3D printing and 3D personalisation to make that perfect hat, and especially out of sustainable materials going forward as well. What we're also developing in addition to that is something topical to use with scalp cooling. And that topical product will allow us to really reduce the impact of hair loss. I'm just going to check the chat function. So what I want to say is just a big thank you to Dr. Bajpai and Dr. Vora, not only for today, but most importantly for the work that they are doing in India and the help they are giving Paxman and Access in terms of really starting to make Scalp Cool be available for patients. And that's a huge support, and we really do appreciate everything you've done and the best practice you're sharing with your fellows around different parts of India. So from myself and also from Access Devices and all my team, we can't thank you enough for what you're doing. And finally, just to say a big thank you to all the speakers today, the panel, the chairperson, Access Devices for putting this on, and then everyone who's attended. So I look forward to, in the next 12 months, hopefully getting out to India when I can travel again and coming and spending some time with you all. But thank you very much, and I look forward to the rest of the presentations. Wonderful. So I believe, is it over to our chairman and first speaker, Dr. Bajpai?
Good evening, all. So we'll start with the first talk, that is the myths and facts about scalp cooling by Dr. Jyoti. Dr. Jyoti, please.
So thank you, everyone. And Kalpesh or Pankti, can you share my slides, please? And it was, it was really wonderful to listen to Richard with all the studies and the progress in this field. So I would like to start with this notion that this was, once upon a time, it was a fancy idea, which was considered that the woman will not lose their hairs even if they are giving chemotherapy. And with this, technological advances, actually it is a truth today. So that is the, great thing about the story. And I'm really touched about the story and the personal experiences Richard shared about his mom. So, many years ago, the technology which was not really advanced and people were not successful in retaining their hairs, but we are really grateful to all the scientists and community who has developed these technologies, and we are able to assure our patients that in a good number they can preserve their hairs. So in the next few minutes, we shall be talking about some myths and facts and about our studies which we conducted in Tata Memorial Hospital. Next, please. So as we know that chemotherapy-induced alopecia is not life-threatening. However, it is one of the most visibly distressing adverse effects of chemotherapy. Clinicians often neglect it owing to the fact that it can be completely reversible. And also they are more focused towards treating the disease. Next, please. So at any time point, around 85 to 90% of hair follicles are in a rapidly dividing phase and are hence prone to damage by chemotherapeutic agents. And essentially, scalp cooling causes scalp vasoconstriction and it reduces the follicular metabolic rate, with resultant diminished cellular drug uptake. This diminished chemotherapy delivery leading to potential increase in scalp metastasis, which was a concern for long period. But again, long-term data has allied this fear. So the past results were of there were a wide variety of cooling techniques used, and they were basic cryogel caps as well as modern scalp cooling systems. And success rates were widely varied from 0 to 90% if you see all the studies all over. And this could be attributed to multiple cancer types being enrolled, various chemotherapeutic regimens, intrinsic patient and or hair characteristics, technical reasons like optimal cap fit, which is absolutely important. And we should be talking more about this in later. And use of non-validated outcome measures, which is again a very important fact when we talk about the outcomes. Use of wigs, subjective hair loss assessment additionally. Next, please. So prior to scalp cooling, in the scalp cooling system, the cooling cap is disconnected from the coolant lines and it is attached to the subject's head so as to cover the entire scalp with a cap. Then the cap is connected to a coolant line and the powering on the system activates essentially the refrigeration unit to decrease the coolant temperature. About the duration, so standardized pre-cooling time of at least 30 minutes, then during entire chemotherapy duration, and a standardized post-cooling time of at least 90 minutes should be ensured when we are offering a scalp cooling to any patient. Next, please. So there are some of the positive randomized trials for scalp cooling, although Richard has already shown. So a meta-analysis as well as other randomized control trials showed that there are positive results with the scalp cooling and there is also acceptable tolerance. However, the common theme in all the above studies was that taxane was the predominant chemotherapy. Only chemotherapy-induced alopecia was measured, and hair regrowth, which again is a very important factor, and it's one factor which is towards normalcy, was not really measured before our study. Next, please. So we have conceptualized this study, which was randomized controlled trial of scalp cooling for the prevention of chemotherapy-induced alopecia in India. Next, please. So essentially, it is an investigator-initiated randomized open-label trial and consecutive women with non-metastatic breast cancer. So they included early as well as locally advanced breast cancer. Again, in majority of the prior studies, we saw that there are early breast cancer patients which were taken, and those were planned for curative intent chemotherapy. We have taken all the patients who were intended to receive both intracycline and taxane-based chemotherapy in sequential fashion, because this is the backbone of chemotherapy and most commonly used. And the non-eligibility was that if a woman is already having alopecia greater than 0 at presentation, a history of any prior chemotherapy, or personal history of migraines, cluster or tension headaches, or cold agglutinin disease or cold urticaria and lichen planus or lupus. Next, please. So there was a central randomization, and subjects were stratified by the sequence of chemotherapy, whether they are receiving anthracycline or taxane first, and they subsequently randomized to either of the arm in 2:1 randomization ratio. So as I already explained about the scalp cooling procedure, so standard procedure was followed and duration was also same. Next, please. So one thing to note that prior to starting of the first cycle, dedicated nurse used to allot a proper cap size, because cap fitting is very important. And also we also experienced in our trial that gradually as the experience become richer, the results were also better. So the optimal cap fitting is a must. So there are 3 sizes of caps available. So one must use the optimum size of cap for the scalp cooling. So how we assessed our results? Alopecia grading was carried out clinically by visual inspection by a primary investigator, as well as by photographing participant scalps in both the groups, and clinical assessment done at baseline before start of each chemotherapy cycle and at primary and secondary efficacy endpoints. Photographs of first 25 subjects who completed at least one cycle of chemotherapy with scalp cooling were obtained at each alopecia assessment. While for subjects enrolled afterwards, the photographs were taken at baseline, at primary endpoint, and at secondary endpoints. Photographs captured here from the front, back, both sides, and from the above. So there were 5 views which were taken for these patients to ensure the objectivity. For further validation, the independent observer outside the study and as well as subject themselves, they also assess their hair fall and hair regrowth, and we have done the concordance relation from the primary investigator's results. Next, please. So primary endpoint was successful hair preservation, which is assessed clinically as well as by a review of 5 photographs and using the CTCA version 4 scale for alopecia, wherein grade 0 was no hair loss, grade 1 is less than 50% hair loss, not requiring a wig, and this is measured after 4 cycles or 12 weeks of chemotherapy. So success was defined as either grade 0 or 1 alopecia, that is less than 50% hair loss, and failure was defined as grade 2 alopecia, that is more than 50% hair loss, requiring the use of a wig or head cover, and participant withdrawal. So after completion of 1 cycle of chemotherapy, if a participant is withdrawing, that was also deemed treatment failure. Next, please. So this is a pictorial depiction of the grading. So grade 0, grade 1, and grade 2. Next, please. So our secondary endpoints were hair regrowth rates at 6 and 12 weeks, which was a novel endpoint we included in the study. And this is defined as attainment of grade 0 or 1 alopecia post completion of all the chemotherapy. The other secondary endpoints were device-related adverse events, which were determined by the patient-reported symptoms and by scalp examination and tolerance to scalp cooling, and defined as percentage of patients who could complete all planned chemotherapy cycles during a scalp cooling. Patient-reported adverse events included feeling cold, headache, heaviness, and they were all recorded in the case record forms. Next, please. So we also record the cap device malfunction. None of the standard chemotherapy-related adverse events were captured inside this trial, and participant reported scores, breast cancer module for quality of life were also assessed at baseline and primary endpoints. So the other exploratory efficacy secondary endpoints was success in hair preservation, which is assessed by independent observer and by subject, as I told before as well. And also the hair regrowth assessment is further validated by independent observer and the subjects themselves. Next, please. Next, please. So this is a schema. Essentially, the patients are randomized into 2 groups, 2:1 randomization, and all the events were recorded. Next. So this is the intention to treat population in the 2 groups, and we can see from this chart that they are well-balanced characters, as far as the menopausal status, their chemotherapy regimen sequence, staging, etc. are concerned. Next, please. So these are the chemotherapy regimen distribution. Again, the 2 groups were balanced. Next, please. So at the time of analysis, the scalp cooling arm, there is 56.3% hair preservation rate, in comparison to the control arm, whereas there is 0% hair preservation. So there is a strikingly different rates. And the effect of drug sequencing was very prominent, and 77% of patients who received taxane first were actually has successful hair preservation at the primary endpoint, that is after the 12 weeks. And those who received anthracycline first, this was around 33%. So there is a statistically significant difference as far as the sequence is concerned. And this is in concordance with the majority of the studies reported. Next, please. So this is the picture, and you can see in the scalp cooling as in control arm, at the primary endpoint, there is strikingly different hair preservation rates. Next, please. Hair regrowth rate was also significantly better. So at 6 weeks, so we have measured the hair growth rate at 6 weeks after completion of all chemotherapy. So a primary endpoint was at 12 weeks or after 4 cycles. However, after completion of the second phase of chemotherapy, as also once 6 weeks are over, then we measured the hair regrowth rate, and also at 12 weeks. This was 89% versus 12% in 6 weeks, while at 12 weeks, 100% versus 59%. So difference was again statistically significant. Next, please. This is the hair regrowth rate in both the arms. Next, please. So this is the success rate, assumption, and concordance rate between the primary investigators as well as independent observer and subject themselves. Next, please. So the concordance rate with PI and independent observers with regard to successful hair preservation was 0.914 at primary endpoint and 0.858 at 6 weeks. The PI and subject concordance rate was also quite significant, and there was compulsion to use head covers or wigs by 46.9% of the patients who received scalp cooling, while 100% among controls. So many of our patients, they do not use wig, but they are compelled to use head covers at least. So this is also one of the important findings we noticed, that how many patients they could be, they're not feeling that they are really compelled to use something to cover their hair bareheaded. Next, please. So it's the same depiction. Next, please. About the quality of life, so 1 of 2 5 quality of life measures was significantly better in the scalp cooling group at the time of primary endpoint as well as at the secondary endpoint. There is loss of hair was reported in scalp cooling arm, 45% at primary endpoint and 21% at secondary endpoint, and while in control arm it is 82% and 53%. Next, please. About the adverse events, so it is pretty well tolerated, and there was a lot of concerns initially when we were beginning this trial, even in our disease management group, our institute review board, etc., that because the climate is entirely different, it is not a cold country, and so how the patients will really tolerate, and we actually put a clause that we will monitor very carefully the 10% of the patients and how they're tolerating, and then only we'll move ahead. So to our assurance that patients really tolerated it very well, and there were no grade 3 for adverse events. Women have grade 1, that is around 57%, or grade 2 around 12%. And they were majority of the time mild headaches and feeling cold. And in summertime, rather it was many women said that it was rather pleasant. So that was one of the interesting observations. Next, please. So the studies suggest that the women with breast cancer who received scalp cooling with both anthracycline and taxane chemotherapy were significantly more likely, that is 57% versus 0%, to have successful hair preservation than those who did not receive scalp cooling. And this is consistent with the results from recent studies which show success rate of scalp cooling in 30 to 80% of the patients. Next, please. So other important findings I wish to bring into notice of the House is that these results indicate that scalp cooling is more effective in women who receive taxane followed by anthracycline compared with the reverse sequence. And similar trends have been observed in other studies also. So this is a very important finding, and we must counsel patients very well about this point. It was also noted that patients who started on anthracycline first had a high chance of losing hair till the time of primary endpoint, that is around 4 cycles, or maybe at the end of the chemotherapy. However, interestingly, these patients then regrow their hairs during taxane phase, And it was, overwhelming to see that while the chemotherapy is still on, they are on their weekly paclitaxel phase, they started showing baby hairs in the scalp, and majority resumed normal hair density at the end of chemotherapy or within 6 weeks. So thus, this facilitates the resumption of their normal lifestyle. So this I found very interesting and important. And when we counsel our patient, we should say that if you are using Taxane first, you will lose your hairs. There are high possibility that you will lose your hairs late. However, if you are even using anthracycline first, there are chances that you will lose your hairs, but you will regrow them fast, and you will towards the end of chemotherapy or within a short period, you will actually there are higher chances that you will gain your normal density of hairs and you will go back to your normal life. Next, please. So among the women with non-metastatic breast cancer receiving chemotherapy with the Taxane and the cyclone or both, those who underwent scalp cooling were significantly more likely to have less than 50% hair loss after the fourth chemotherapy cycle compared with those who received no scalp cooling, and this merits wider application. Next, please. So the limitations were that a small sample artifact. Furthermore, the primary endpoint was successful hair preservation after 4 cycles of chemotherapy, which could be higher than the efficacy at the end of all the cycles. However, notably, we all see in our clinics that majority of the women attained grade 2 alopecia after 1 or 2 cycles of chemotherapy, especially if you are using anthracycline. So this is a well-designed endpoint. And the other randomized trials by Naik et al., which was the approval trial for FDA, also assess the alopecia at this time point, which again proves its clinical relevance. So chemotherapy type, sequence, and technicality related with optimal cap fit are potential confounders for real-world outcomes. And again, the training session for nurses is very, very important. And I think this is the bottleneck. And if the cap is not optimally fit, even at certain points, those points patients are losing hairs. So this is one of the very critical point I would like to bring into everybody's notice. And also there are 3 sizes of caps available, and majority of our patients fit well into a small size cap because of the head size. So that part also should be very well taken care. Next please. So the final conclusions. This is the Paxman scalp cooling system was found highly effective in reducing chemotherapy-induced alopecia with a clinically meaningful benefit in these breast cancer patients. And the best effects are with Taxane-based chemotherapy, modest with anthracyclines. So if we start with anthracycline, patients should be warned that their hair preservation is expected to be somewhere around 30 to 40% based on the existing literature. However, the regrowth rate is faster and they start during Taxane phase. And in many, by the completion, they will retain their normal hair growth. Treatment was safe and very well tolerated, so there are no safety concerns. And the staff training and adequate cap size is critical. Optimum cap fitting is a must. And perhaps way forward is a personalized caps, and about which I am already in talks with Richard, and I hope you will give me some good news soon. So thank you very much.
Thank you, Dr. Jyoti, for the very clear presentation. Any questions?
There was one question which was asked, but I believe Dr. Vora has answered it on the chat function, and that was relating to: would you encourage a patient, or would you continue scalp cooling with a patient even if they've already lost over 50% of their hair? So your view on that would be interesting, Dr. Bajpai. Right.
So as I said, this is a very important question, and yes, because even if the patient they lose more than 50% of hairs during chemotherapy, their regrowth rate would be better. And as we have shown, it was statistically significant difference. So we must encourage them, and we can show them the results also for objectivity, that if they continue to cool their scalp in spite of losing more than 50%, there are high chances that they will regrow. The regrowth of hair will be much better. So we should.
Can I ask another question? This is Dr. Mansi. I'm a medical oncologist from HCG. Good evening, Dr. Bajpai. Thank you for the presentation. As routine, now, have you switched over to Taxane followed by Anthra for patients who are receiving cool cap? Like, is that the protocol, or how are you doing it? How do you decide in which patients can use taxane and follow the answer?
So even in the protocol, we have not switched to only those regimens. We were using a majority of the time. We start with taxanes in the patient who are HER2 positive. So taxane along with trastuzumab is our default regimen. So those patients actually receive taxane first. Otherwise, we generally give anthracycline first. So we have not shifted during the trial time. Also, even the later, as I said that if we are using taxane first, then the chances are that they will lose their hairs later. And if we are using anthracycline first, then they will gain their hairs later, early. So it's a choice between the two. Ultimately, patients are getting benefit irrespective of the sequence.
Okay, thank you.
And also, I believe that.
One of the thing, can I also add, Dr. Jyoti, something?
Yeah, please.
Also, Dr. Mansi, one thing what we have to see, weekly paclitaxel, the success rate with scalp cooling is phenomenally high. Like in my practice, almost more than 80% of patients till the time they are on weekly paclitaxel don't lose hair. So I counsel them that, okay, 12 weeks are gone with a lot of hair on your head. AC, there is a 40 to 50% success rate chance, like that is what I experienced. 50% of patients who will lose hair only for a limited duration of period, compared to if you use AC first, they lose their hair during the entire duration of chemotherapy. They are going to have Dr. Jyoti was doing the randomized control trial, like I do in a real world setting. Patients' perception, even after 70% hair loss, if they have hair here, they still feel very happy and they want to continue scalp cooling. Give them realistic expectations. They actually want to continue. That is what my experience has been.
So very rightly said, Amish, and I completely agree with this. That you have to set a realistic expectations. So some patients have the belief that they will not lose any hair. So one of the patient who has a phenomenally good result in spite of giving anthracycline first and later, she was a role model kind of a patient. But then also because she lose all 10-12% hairs, and in spite of we have shown her the pictures, the WHO grading everything, but because she had in her mind that I should not lose any hairs, that kind of a very young woman, very conscious. So, that kind of expectation you have to, every time I needed to counsel her for half an hour, oh, you are doing great, I am losing more hair than you without anything. So the realistic expectations and how you are putting in, how you are counseling, and also the patient sitting in front of you is very important.
Okay, thank you.
There was another question in the chat box regarding platelet-rich plasma and new hair growth. Anybody to comment?
Sorry, can you please repeat?
The platelet-rich plasma, because this dermatology people used to use platelet-rich plasma for hair growth.
So I'm not the best person to answer this, but what I'm aware, yes, there are some studies, and perhaps they are in early phase only. They are trying to develop this, and I think if anybody is having any clinical data, then at least I'm not sure about it.
Okay, I think then we'll go for the next talk by Dr. Amish. There is scalp cooling in other than breast cancer.
Yes, I think my topic is breast cancer and beyond breast cancer.
Oh, yes.
I will share my screen. Are my slides visible?
So I wish, Amish, your topic could have been the one which was said, and
My
then
slides visible?
No, only the screen is seen.
Not yet, sir.
Slides not seen.
I am very poor in technology. My slides.
Okay, yes.
Hello?
Yes,
You have my slides?
Now we can see.
Yeah, put my slides.
now we can see you in your slides.
Make it full screen.
No, but I can't see my slides. It is visible.
Yes, we can see. Yeah.
So I'll just do it. I don't trust myself. So this is second slide. Are you able to see second slide?
Yes.
Okay, perfect. So I will start. Thank you much for giving us this opportunity. Which was very important was it's thing he also said, told me, if I remember, when his 9 weeks.
Dr. Vora, sorry to interrupt you, your bandwidth is very low. So we are not. Hello? Hello?
Hello.
Yes, sir.
Hello, Kalpesh.
Am I audible?
I think
Yes,
we are
sir.
not, it's not moving well. So I think maybe Kalpesh, you can
Yes,
project
yes.
the slides.
Yes, yes. Pankti,
There
please
might
move
be-
the slides.
There might be bandwidth problem.
Okay, sir.
Yeah,
My colleague is loading your slides, sir.
yeah, Kalpesh,
Yes,
can you
yes.
project the slides, please? Okay, okay. And I cannot start my own video because host has stopped it.
No, sir, it is due to the bandwidth. That's why, otherwise we cannot hear you.
Okay, okay, okay. Understand. Am I audible now?
Very well, sir. Go ahead.
Am I audible now?
Very well, sir.
Perfect. Okay, understood. Thank you so much. So we know that we have two commercially available devices. One is Paxman and one is DigniCap. And I will speak about my experience with Paxman. Next slide, please. Keep on pressing next slides. Yeah, keep on pressing. Okay. The only last point I wanted to highlight about cancerism, I think one of the most important point is the moment you have hair loss, you are announcing to the world that you have cancer and you are undergoing chemotherapy. Moment that happens, the cancerism word sets in the society. You can be discriminated at workplace, discriminated by your friends and family. I think the scalp cooling gives us power to decide when and whom do you want to tell. Next slide, please. Can you go to the next slide? Richard has defined it very nicely. So I'm not going to go into the details of that. Next slide. The first randomized 2 large randomized trials, one by Dr. Nangia, one by Rugo, both by one company, one by another company, both successful. I think one of the very interesting point which came out of both these randomized studies is that the control arm is insignificant, because even if you have 20% success rate, 20% of females or males where you have used scalp cooling will retain their hair, which is far superior compared to 0% when they don't use scalp. If you press on the next slide, it will come faster. Yes. So the success, as was shown by Richard, in one study it was 50%, in another study it was 66%. In the 50% study by Nangia et al., they had used AC and Taxane both, while in Hope-Rubo they had used Taxane predominantly. Next slide, please. We can go through these slides because Richard has already told. This is Hope-Rubo, again JAMA. Next slide, please. Yes, so 66% was the success rate. Next slide, please. This was one worry which again Richard also had covered, and I think Dr. Jyoti also covered. In fact, in NEJM, there is one question which has been asked just 2 months back, that can there be a micrometastasis lingering around in scalp if we have used scalp cooling, and in future, can they have metastasis either in scalp or in systemic metastasis? This is just a hypothesis. Nothing has been proven. Next slide, please. In fact, what Dr. Hope-Rubo presented, which I have shown in highlighting, not a single patient developed scalp metastasis with a median follow-up of 30 months. And as Richard showed, 0.6% and 0.4% was difference between scalp cooling in scalp cooled versus non-scalp cooled. Next slide, please. So real life experience of scalp cooling in Europe ranges from 50 to 80%. Next slide, please. There was an Asian experience. Of course, Dr. Jyoti was one of the first from India, and there was an Asian experience, but it was very, very limited data. Next slide, please. Next slide. Okay, I'm not going to go into the details of Dr. Jyoti, but I am proud and honored that there is a randomized trial from Dr. Jyoti and from Tata Hospital in this. Next slide, please. So I'll straight away go to my experience. At Hope, we purchased the machine after it was FDA cleared in April 2017. I thank Richard and Paxman and Access Devices because there was extensive 2 training sessions. I believe training is the key to success in this study. We were using especially Hope, and one more, the machine breakdown happened more than what we could handle. We believed probably it was because of transportation. So we started using this machine only at Hope. And I believe that seeing our success rate, Richard will immediately write an email to me that, Dr. Vora, I'm giving you one more machine free of cost. Next slide, please. The photos, what I'm going to show, we have taken the consent from each and every patient before taking photographs, not seen. All photos are real patients who have taken chemotherapy at home. Next slide, please. So, as always, everybody knows there were first 2 patients were total failure. Paclicarbo, 90% hair loss after first cycle. The word spread very fast. My patients were very reluctant. I was very furious. I started writing emails to Paxman and Access Devices that I want my refund. And I spoke with Dr. Jyoti also. Next slide, please. And then came our third patient and first success. If you can see this patient is after 4 AC and 12 weekly paclitaxel. The patient stays in independent house, and she defined her success as her neighboring auntie was very nosy female, and she didn't even notice once that she is undergoing any chemotherapy or any type of hair loss. So she defined her success in that terms. Next slide, please. So they said that my mom probably maybe lost 50% of hair, but she retained 100% of her confidence. That was from the same patient's son. Next slide, please. We learned many, many lessons after that, but initially, let's see some results. Next slide, please. So 3 patients had 0 hair loss. Now, I was surprised and I was wondering how can it be possible in loss of completing the total treatment. And next slide, please. Then I saw the original articles from JAMA, and I realized that there were few patients like arrow where I have put that 5 patients in from Dr. Nangia's study had zero hair loss. So we were not the only one with having zero hair loss, but trust me, it feels amazingly, amazingly great when patients do not lose hair. Next slide, please. Now, this was what Dr. Mansi also said, and this is what I wanted to show. Both these patients had barely manageable hair after around midway in the treatment. In fact, almost 60 to 70% hair loss was there. Both these ladies flatly refused to stop scalp cooling. They saw other patients completely bald. They said, no, we still want to continue with scalp cooling, and we continued scalp cooling in these patients in spite of that. And if any of you do not know that these patients are undergoing chemotherapy, I'm sure people in this audience also would say, oh, there is something else other than chemotherapy in these patients. Next slide, please. This is our flagship, the way Dr. Jyoti mentioned, and exactly the same. After 2 cycles, this lady lost 10% of hair and she was crying and wailing and crying. And he said, come on, this is your head. And this is the photograph taken after again 4 AC and 12 weekly paclitaxel. This is the real photograph, and she has been a flagship of success. Next slide, please. Many more. We did not restrict ourselves to breast cancer because I was not doing a randomized trial. We were of soft tissue cancer, ovarian cancer, non-Hodgkin's lymphoma. Next slide, please. We use scalp cooling wherever we felt. Some of the learnings were, these were the patients with short hair. And if you have a short hair, you preserve more hair with scalp cooling. In fact, in one of the instructions in Paxman's site, they have mentioned that you can cut short your hair before going for chemotherapy. That gives you more results. In fact, Richard, you mentioned about the Japanese study. This one particular lady in extreme left corner is a Japanese lady. And we used, she was having colon cancer. And we used during FOLFIRI, and this is post-irinotecan, 8 cycles, and this is her hair retained. Next slide, please. This was surprising. Again, I still do not have an answer to both these young ladies in their 30s. This is after 4 AC. Contrary to what Indian experience is that AC gives rise to more hair loss compared to taxane. These ladies have, this is the hair after 4 AC. I couldn't believe that. Next slide, please. But this after 3 paclitaxel, this was the condition of the hair. I would call it as a failure in terms of the success rate if you define. But again, both the ladies continued scalp cooling till 8 cycles, and both of them had their hair regrowth. See, I did not use it as any endpoint, but going by Dr. Jyoti's presentation, I think I should start using that now. Both of them had hair regrowth within 3 to 4 months of completion of the treatment. Next slide, please. So as I said, both of them were very happy because their duration of alopecia was very, very short and hair regrowth immediately after 8 cycles. And in fact, during this time, my wife had visited LOC and she also was told, same at LOC London, that continue scalp cooling, the hair regrowth is better. Next slide, please. Surprising success and failure in some patients. This is one particular patient, 3 weekly Pacli carbo in full doses. I use scalp cooling, telling this patient that you will not retain your hair because 3 weekly Pacli carbo do not give good results. But this was a very good result. Yeah, you can go to the next slide, please. Now, this was the hair loss pattern, which I couldn't understand. I checked the scalp cooling fitting also, but the fitting was there. It is just at the hairline receding, and we still couldn't understand. Next slide, please. Next slide, Jyoti has mentioned about fitting, cap fitting, and it is extremely important. This is very, very interesting. We use eribulin, metastatic CA breast, 2 cases back to back. Both the patients were together. Both metastatic breast cancer, triple negative, and second line. Next slide, please. So one patient lost complete hair, the other patient retained hair. Very unfortunately or surprisingly, the girl who retained her hair did not respond to chemotherapy, and the lady who lost her hair had a metabolic CR with eribulin. Again, this is to show that hair loss with or without scalp cooling has got no relation how you respond to chemotherapy. Next slide, please. Males. Now, this is a new addition which I have started collecting the photographs. The top photograph is prostate cancer, 3-weekly docetaxel. The patient exactly had these many hairs before cycles, and this photograph is after 4 cycles of docetaxel. He insists on scalp cooling. He will not come if the scalp cooling machine is not working on that particular day. The bottom photograph, one photograph with the mask, what you see is during COVID times. ABVD, all 6 cycles complete. This is after 12 doses of ABVD. And the gentleman next to that is seminoma. I know carboplatin alone does not give rise to hair loss, but we use carboplatin AUC 7. And the literature said 12 to 14% of patients can have grade 2 alopecia. He did not have a single hair loss after 2 cycles of high dose carboplatin. Next slide. In terms of figures, again, I had the luxury. I define success by 2 parameters, visual impression and patient satisfaction. Next slide, please. Has anyone in your family who you know, have they asked you about cancer diagnosis? If no, that means it is successful. Next slide, please. So total number of scalp cooling patients in my center have crossed 100 in fact, but I have the data of 84 patients. I still need to compile the data. We have 5 males and 79 females. Breast cancer is 52 and others, as you can see, I had said. There were 2 patients who refused scalp cooling after 2 cycles. So you can call this as an adverse event grade 3 as per Dr. Jyoti's this thing. One patient had a migraine problem. A lot of headache. The others couldn't tolerate after each scalp cooling, so they refused. The oldest patient in my practice is 71 years of age. Next slide, please. So this is a 71-year-old lady. I have taken the consent. She's a wife of ex-RAW chief of India, Research and Analysis Wing in India, what we call as RAW. And this is after 15 cycles of chemotherapy. Why 15? Because on the 16th cycle, the patient's performance status was on the lower side. So we skipped the last cycle of chemotherapy. Next photograph. Next slide, please. So 76% of patients retained visibly good hair and were happy with results. And 75% of breast cancer had their hair preservation, what you call more than 50%. Next slide, please. I would skip this because Jyoti already has covered and Richard already has covered. Next slide, please. Yes, next slide, please. Lessons learned is that caps have to be touching all parts of scalp. As I showed you the flagship, this particular lady had certain areas of scalp which were not touching. I told husband, I told brother, and I told sister to stand there and keep pressing on the cap so that it touches all parts of the body. You get more success with that. Same team of staff, as we all said, keep lot of blankets available in winter because in Delhi winter is very cold. Do not move machine much. If possible, keep a spare machine ready. Next slide, please. Machine breakdown happens. Screen goes blank, coolant not up to the mark. Fuse blows away very frequently, not cooling enough. But I must say that Paxman and Access devices are available 24/7 and they are always there to help you. In fact, in one particular time, 7 days machine was not working And I wrote to Richard. Richard sent one of the person specifically for the machine. That person stayed in India for 3 days, cleared my machine, and then he went back. Thank you so much for that. Next slide, please. I believe every patient should receive scalp cooling if possible. The same question I asked to Dr. Peter from LOC. And I asked him, I said, what percentage of patients in your center get scalp cooling? He said 100%. Why should any lady not get scalp cooling? In their center, I understand they have 7 scalp cooling machines, if I am not mistaken. Dr. Peter Harper told me about that. Maybe across there are 4 centers, maybe in 1 center. Next slide, please. So this is a graphical. Of course, my data is not published data, so I cannot do that. But if you see Dr. Julie Nandya, Dr. Hope Rugo, Dr. Jyoti Bajpai, and Hope success rate. So we have the highest success rate as compared to the other 3 studies. But again, I say mine is not a published data, so this can be taken with a pinch of salt. But I truly believe in this result, which I have seen with my own eyes and monitored them. Next slide, please. Some unique learnings, 2 ladies from African origin. I'll finish in next 2-3 minutes. 2 ladies from African origin did not lose a single hair. Whether genetically predisposed, whether short hair, whether curly hair, we do not know. Next slide, please. Again, age no bar I mentioned. The ladies are 69, 70 and 71 years of age. And all these ladies have completed their chemotherapy, and this is a photograph after the same. Next slide, please. Boundaries no bar. These ladies from across the border, our neighboring country, Pakistan. Next slide, please. This was a walk. We had one walk. This lady who has used scalp cooling machine, and you can see her hair. This is immediately after chemotherapy. She joined us in marathon, and she again believes in scalp cooling. Next slide, please. I love to keep this photograph in every presentation of scalp cooling, because this lady, she's a teacher, ex-teacher. At the last chemotherapy, I said, can I use your photograph? She said, yes, but I want exactly this pose. I said, why? She said, my next photograph probably will be after my obituary. This is my last claim to my fame, so let me have my fame. So I always use this photograph. Next slide, please. Special thanks to everyone in our team. We have the same set of nurses. My wife, who's in charge of scalp cooling machine, she's an engineer. Mr. Ravi Shetty from Mumbai, and Paxman team, access devices, and all our team staff member. Last slide, please. Next slide. This is our Hope team. Thank you so much from Hope, and thank you very much. I stop my lecture.
Thank you, Dr. Amish. Again, any questions or comments from anyone?
Dr. Amish, if I can ask, this is Dr. Meenu Walia.
Yes, ma'am.
Amish, I just wanted to know, in your experience, how bad is the headaches which patients frequently complain? And do you find that the headaches are more during the winter months compared to the summer months? And what?
No, ma'am. There is. Yeah. Sorry. Third question you were asking.
Yeah, you continue. I'll ask it.
So I'll tell you, ma'am. What happens? Headache frequency is completely different. Different people. There is no pattern. There have been some instances where patients, they say, hey, I am getting so much of headache, I don't want to continue. I tell them, give me half an hour. After half an hour, if your headache continues, I will stop. Invariably, their headache disappears after half an hour. Maybe it's a numbing effect of the scalp cooling cap, or maybe they get used to it, or maybe the metabolism after chemotherapy starts increasing the basal metabolic rate of the body. But invariably, they tolerate it well. No, none of the patients have said that the headache continues for 2-3 days after scalp cooling. At least I was lucky, because that is what the literature also has mentioned about that. During winter, no. I don't think that the headache was more during winter. It was purely to do with patient to patient.
And what are you normally doing for headache? Do you intervene with paracetamol or something, or it gets away on its own? Which you said, no, just lasts for a few hours.
I have. Yeah, so I have two patients, as I told you, ma'am. One was migraine and one was sinusitis. They stopped using scalp cooling because they said they had an attack of migraine and sinusitis after both the times we used. They used their routine sinusitis and migraine treatment and they got better. But I also felt that it is better not to use that. I tell patients to take Prasad if they get headache. Fortunately, not a single patient has turned back to me and said that we have intolerable headache, what to do. So grade 1-2 headache, not more than that. And I think that is what Dr. Jyoti also has seen.
So I'll request Dr. Jyoti also, is her experience also somewhat similar on this, on the headache part, that it doesn't last for beyond few hours?
So Dr. Walia, in my experience, a majority of the patients who complained about headache that were grade 1 and 2, and although we intervene and we give paracetamol also, and at times they're accompanied by cold sensations. So in my experience, if we provide them more blankets and those warmth, then also it helps in improving. So we were using paracetamol for these patients, but this is generally a temporary headache, and majority of them few hours or maybe 1 or 2 days. Few patients experiences 1 or 2 days later also, but they were few.
Okay. Thank you.
Thank you all. Then we'll go for the panel discussion. I invite Dr. Senthil to start the proceedings.
Kalpesh, you can show my slides, Kalpesh. Okay, so we've had a nice session educating ourselves about the Paxman scalp cooling machine. We'll do a quick panel. We're running short of time, I suppose. The first picture, So Amish and Jyoti, after using the Paxman, your hair also seems to have been preserved, but as you can see my picture today, my hair seems to have been lost after using the Paxman machine. So that's more on a lighter note that I wanted to start. So our panel today will be on factors influencing the effectiveness of scalp cooling in the prevention of chemotherapy-induced alopecia. Next slide, please. Okay, let me ask the youngest, as I assume, Saurabh Prasad from Kingsway, Nagpur. Saurabh, are we disease-centric? Mr. Richard started by saying that you're more worried about the disease rather than the patient. So what is your experience, Saurabh?
Sir, I have a very short experience. I purchased this machine this year in, I think it was functional from April, just before the lockdown. It was a very bad time to purchase this machine. But in last 5-6 months, I have put around 14-15 patients on this machine. And it has been a variable result. I couldn't attend all the presentation, but I have, when I use it post AC and paclitaxel, 2 to 3 of my patients have stopped after 2 to 3 cycles. And I learned a new thing during this presentation that if we use paclitaxel before anthracycline, the compliance would be better. So this was a new thing for me to learn from the seniors' experience about this, how to use this machine.
Kalpesh, next slide, please. Dr. Meenu, how many patients, what percentage declined chemotherapy in your practice because of hair loss? Amish, 8%. What is your experience, Dr. Walia?
So 10%, approximately 10% of the patients do decline chemotherapy because of hair loss. And apart from that, Dr. Senthil, what I want to say is, more than people who decline straight away, sometimes you find the patients coming late for chemotherapy. Surgery has been done, not taken adjuvant for quite some time, or they have been having a lump for a long time and not really gone for treatment for the fear of probably chemo will be done and hair loss will occur. So people presenting late with the disease is also quite common. If we take that percentage, probably the percentage goes higher.
I agree. Jyoti, what is your experience at your large center, Jyoti? How many run away because they will lose hair?
Senthil, I would say that patients are afraid and they are aversive, with the thoughts that they will lose hairs. But when we counsel them well, it is around 10%, 10% or even lesser than that they actually run away. But many times they delay their chemotherapy. That's what my experience is, that when we, ask the young ladies who are coming from remote Bihar, UP, etc., that why you didn't come in time, they many times they said that, we have seen somebody who is on cancer treatment and they lose their hairs. That make me really afraid, and I'm reluctant to come over for this kind of treatment. So there can be delays also. There can be reluctance to take chemotherapy because of this complication. And previously I used to think that this is more is more common in the educated and the outgoing kind of population, but contrary, I found in many times in the general OPDs, one patient, which was actually very alarming event. She told me that she was abandoned with her two daughters because she developed a breast cancer. After once she developed alopecia due to chemotherapy. She was a villager and she was abandoned. So that kind of thing is existing. And although I will not be able to give you the exact figures, but many patients are apprehensive. They don't completely, not taking, but they are very apprehensive.
I very much agree. Beyond the small ramifications that all of us think alopecia is all about. Mr. Pax, Mr. Richard, can I bring you in here? Amish showed us some pictures of patients with non-Hodgkin's lymphoma and so on. I screenshot this from the Paxman website. It specifically mentions about certain things that I've listed here and highlighted in the box. Is it because there are some specific reasons that we should be using the device, or is it because there is no data? Mr. Richard?
I think and thank you very much for bringing me into the discussion here. I think the reality is it's the lack of data we have with hematological disease. And we do now see a number of physicians that are becoming more relaxed with the use of scalp cooling with specific hematological disease, with the likes of non-Hodgkin's, which of course is slightly different than perhaps leukemia in terms of its state. So we are seeing a shift in the use, and I think that will change as and when we have more supporting data with regards to its safety. But a historical concern, which I think is very similar to the scalp metastases one with certain hematological disease. So I think watch this space, and there may be more use of scalp cooling in this area in the future.
Great. So it's more because we don't have data. Amish, you must be having the maximum experience. Have you got any patient with liver disease, renal disease, which I've again highlighted there, when at least the website says the machine is to be avoided? Squamous carcinoma of the lung and things like that. Small cell carcinoma. Amish?
Yeah, so just wanted to add the question which you asked, Richard. In fact, my first patient of lymphoma was a lawyer. I didn't know this contraindication existed, and before CHOP, he showed me that, doctor, why are you using scalp cooling on me? Because the website says it is contraindicated in non-Hodgkin's lymphoma. Then I Googled, and there is one phase 2 data on scalp cooling where they had used 16 patients of NHL and CHOP. So I showed that, and the gentleman agreed. And in fact, he had 9/10 of 5th cycle. Unfortunately, the machine broke down on the 6th cycle, and he had complete alopecia on the 6th cycle.
And he didn't pull you up for that, Amish?
Not as yet. Not as yet.
All the good work done was lost in the last cycle.
I swear.
All right. Any experience with liver disease, kidney disease? Kalpesh, next slide. Amish, any experience with those liver disease and kidney disease patients, Amish?
I see. If the liver failure or kidney failure, anyway, we don't end up giving chemotherapy to these patients. If you're asking me about liver metastasis, I have used in liver metastasis, like that Japanese lady, Folfini, I used.
No, Amish, I'm not meaning that. There are always some patients with borderline kidney function, borderline liver function, who come to us with adjuvant therapies. We kind of adjust the dose and push a little bit, that kind of a situation.
I'll have to check my data. I'll have to
honestly. Often you're not able to recollect.
No.
All right. Amish, on that front, what are your tips to make sure that the caps fit best?
So we have 5 caps right now of different sizes. And I am in talks with Paxman and Access Devices. In fact, we were in talks, and because of COVID, we couldn't take it further. I have had few patients who didn't mind paying for individualized cap also. So we had worked out the logistics that in 10 days time, Paxman would courier us the fitted cap. I feel if that is available, that is the best thing what we can do. In addition to that, honestly, this is a mantra which I have used in more than 15 patients. If the cap is not fitting well, you have to press on the cap and it works well. People get tired. So I use husbands, I use brothers, I use sisters, sister-in-laws, and they keep doing that for 2 hours, 3 hours, whatever.
What about mother-in-laws? What about mother-in-laws?
You think mother-in-law will do that for 2 hours on daughter-in-law?
Might be take the hair off, I suppose. Amish, sure. Yes, I understand. So I think the point is that you have to make sure that the cap is fitting well. As Jyoti had written in her own editorial, it says ill-fitting caps leads to gaps. I like that statement, and so I just copied it and put it up there. Nice, catchy sentence, should I say, Jyoti?
True.
What about type of chemotherapy? Dr. Meenu, you must have also used it. Are you very choosy regarding the type of chemotherapy in your patients, or anybody who comes in who you think is eligible should go on the device?
So I do not compromise on the type of chemotherapy I want to give for that lady, irrespective of her preference for hair loss or if she's comfortable or not.
Right.
So I will not change the sequence. I generally using anthracycline followed by taxanes, and do tell them that in spite of these caps, there may be 50% hair loss. So I will not change the chemo protocol or.
What is your explanation for the chemo sequence, and the alopecia results that you had with the machine, taxanes to anthracycline versus the other way around? Do you have any do you have any hypothesis to explain that?
So, Senthil, hair loss in general depends upon the alopecia potential of a particular drug. So, as such, also you will see in the clinics that when we use weekly paclitaxel, the hair loss is not as prominent as when we use anthracyclines. So, and it's quite later also. So, it's per se the drug potential to leads to alopecia. That's what is my understanding, and throughout the literature, when I
know, but because my thinking was that at the end of the 8 cycles or 6 months or 4 months of chemotherapy, ultimately the total amount of drugs that you received is constant. So, it actually defies logic a little bit, but it seems to be happening consistently. Mr. Richard, do you have any explanation to say as to why the sequence matters in terms of the alopecia? And then, Amish, if you also have some thoughts on that.
Just one addition.
Yes, Jyoti.
Because you see that after anthracycline, generally after 1 or 2 cycles only we see almost complete alopecia, which is not the case in weekly paclitaxel in general, even when we are not using. So that's why I feel it is a potential.
Okay, Mr. Richard, and then Amish.
Yeah, it's a little bit unknown as yet, and we're trying to look into it from more of a biological level with some of the work we do with the University of Huddersfield. But one argument, which may be wrong or right, is that as the taxane on the hair follicle seems to be less harsh, or at least scalp cooling would be more effective with it, we believe perhaps that some of the effects that the taxanes had on it, the hair follicles are probably slowed down in terms of growth, so they're not as active as they normally would be. By the time we hit the anthracycline, there's some already level of protection and less targeted effect. Again, that's only a hypothesis, and to be quite honest, I think we're unsure. It seems to be working, and where possible, we would encourage it.
So, Senthil, thanks for asking. I don't believe that AC or T has any difference in terms of scalp cooling success rate. Japanese people had shown that AC is more successful than taxane.
Right.
In my experience also, certain patients, amazingly wonderful hair after AC but lost after taxane. In ovarian cancer, when we used 3 weekly paclitaxel and carboplatin, the hair loss was maximum compared to that. So I don't believe. In fact, just planning to start a study about hair health before starting scalp cooling. I have roped in one dermatologist. We will take a sample of hair to see whether it is in anagen phase or ketogen phase, and see the hair health and see the success of scalp cooling. I truly believe the hair loss is directly proportional to the hair health before starting scalp cooling.
Dr. Mansi and Saurabh, would you want to change your sequence of chemotherapy after hearing to what the data that has been alluded to so far? Taxane followed by anthracycline, because I personally believe that the sequence doesn't matter, but would you change so?
Dr. Senthil, this is Dr. Mansi. I think I am kind of tempted now looking at the numbers, to be very honest. That's why I asked Dr. Bajpai that, how does she decide which patients can get taxanes first? And so apart from the TH patients, even for patients who are either triple negative or I think early stage disease, either in adjuvant therapy, I don't think I would mind. Even in the neoadjuvant, I'm kind of tempted for patients who are going to use scalp cooling. I don't know if there's anything wrong with that. I mean, in terms of...
I don't think so. I don't think so at all. I don't think, as long as you're delivering all the drugs, that's all that matters, is my humble opinion. Saurabh, Kalpesh, change the slide.
So, Senthil, sorry, very quickly, what Mansi said, the patients, like Dr. Meenu said, that the patient will not take chemo if they have hair loss. I try to use weekly paclitaxel first, because I know 80 to 90% of the times with scalp cooling machine, she's going to retain her hair and she's going to get the confidence, complete chemotherapy. AC, it's God's wish whether the hair is further retained. That is one particular place it has been very helpful to me.
I'm sorry, can I just pitch in here? I usually use more dose dense, like every 14 days rather than the weekly Pacli. Does that seem to have any change in the benefit?
Jyoti, you want to take that?
So I think the success rate would be best with weekly paclitaxel. And this is, although we have used in majority weekly Pacli only, but I have had a chance to discuss this part with Dr. Hoplugo also, who also had a very rich experience in this regard, and she also feels that this weekly regimen and especially taxanes is having a better success rate. So I just want to ask Amish, you said that you don't believe in sequence, then why would you choose a lady who don't want to lose her hairs on weekly Pacli? You looks influenced with me.
No. What I said is that if you use dose dense chemotherapy, then the sequence does not matter. But if you use weekly paclitaxel, as you rightly said, in weekly paclitaxel without scalp cooling, what is our experience? After the 5th weekly paclitaxel, the hair starts thinning. After 8th or 9th weekly paclitaxel, you have 50% hair loss. By the time 11th weekly paclitaxel, you have 80% hair loss if you don't use scalp cooling machine. If you use weekly, the success of scalp cooling machine is exceeding 80%. That is what I said. But in dose dense, the sequence does not matter according to me.
Right. So, I believe that this is multifactorial, no one factor. I feel that this is a drug potential as well as the host characteristics. So, as you said about the hair follicle, yes. So, also I feel it is age related also. So, in general, in old age, there is high propensity of hair loss. There will be some exceptional people who will retain their hair still late. But, there is some relation with age factor also, hair structure, hair strength, all those features, put together, perhaps will make a decision.
Jyoti, I wanted to ask you about the hair regrowth. I think the other questions you've already taken. So the regrowth, how did you measure? The reason why I'm asking you this is that patients who were on the machine had lesser hair loss. So they are likely to get their hair back faster compared to somebody who was not on the machine and had 100% hair loss. Is my understanding correct, or am I missing something somewhere?
So see, it is, if a lady is put on anthracycline fast, there are, in our study, we found that 33% of the patients only could retain their hairs at the end of the primary, till the time of primary endpoint. But when they start on taxane phase, they started growing their baby hairs, even if they have complete bald before that. So this regrowth rate is found to be faster, and again we measure with the same WHO grading that at the time of 6 weeks or 12 weeks, they should be able to retain grade 0, grade 1 hairs in their scalp. So that percentage, that proportion is much higher in comparison to the patients who are not on scalp cooling.
Correct. I don't get you clearly, Jyoti. Just sorry to persist on that. My question was, let's take 100 women who were on the machine versus 100 who were off the machine. Mm-hmm. The 100 who were on the machine as a group would have lost less hair, mm-hmm. while it was 100% hair loss for women who were not on the machine. Mm-hmm. Right. So when you're talking about regrowth, are you talking about the percentage of patients in the group that used the scalp cooling but had more than 50% hair loss? Are you looking at the regrowth in that, or the group as a whole? Because if you take the group as a whole, obviously it's likely to be faster. So that's the reason why I asked you, am I missing something?
So basically, it's a transition. If somebody developed a grade 2 hair loss, then to come back to grade 1 or grade 0,
okay,
that rate.
Okay, that rate you're talking about. So it's almost like an individual rather than the
yeah.
Next slide, Rajesh. Next slide. Okay, so let's come to the logistics. So Amish, let me start with Dr. Walia. Madam, how do you minimize daycare time, because you're going to get stuck with half an hour before setting up the machine and then 90 minutes afterwards? How do you? What are the things you do to minimize the time delays and so on?
So we actually, all said and done, we are not able to minimize the time to too much. You start the cooling at the time of pre-medication.
Right.
So before, as soon as the patient comes, and sometimes you are waiting the reports, or probably before you have not even yet started pre-medication, you start cooling at that point of time. So that is the only way. And sometimes if we are too much pressed for time, so once the chemo is completed, the patient is shifted to a different waiting room with the discharge formalities being done, the TP approval and everything, and the cooling continues. So that is all that we can do. That's it.
Saurabh, what do you do? Saurabh, are you around?
Yeah, yes.
Yeah, please.
Yeah.
Logistics.
I start the cooling before before or with the pre-medication, so that 1 hour cooling is is done before the chemotherapy is started. And as usual, for 1.5 to 2 hours post cooling we do. We don't have problem with the space, so we don't have to make them wait in the waiting hall. We continue with the same in the same bed where they are taking the chemotherapy.
Very good. So we have Dr. Mansi. What is your experience so far with the device?
So we started using the device since last, I think September or October. So it's just been almost like a year or less than. We've had 28 patients so far, and like looking at the data and everything, I've kind of used it more in patients with Paclitaxel. I do mainly breast and gynae, so I usually have patients with either AC taxane, TC, or Paclitaxel in ovary patients. So I would say we've had about 50% of patients with less than 50% alopecia. In my experience, I've always used AC followed by taxane, which might change now, but they've not really retained their hair. In terms of side effects, mild headaches, just one patient discontinued because of side effects, and she had severe urticaria post 3rd cycle of PC. And we weren't really sure what that was because of, whether it was a drug rash or something like cold-related urticaria. So in the 4th cycle, we had not given her the cool cap. But I've not had a good experience with AC.
Okay, Dr. Walia, what about your experience?
Sorry, can you come out?
Your experience with the machine on the whole with your patients. How many patients have you had, and what's your percentage success?
We have not had many patients who have really consented or really wanted to venture out for the machine. Once you tell them, probably the success rate is somewhere around 50% because they need to pay extra at our center for the charges of scalp cooling. And whatever patients we have used, probably the success rate is to the tune of 40 to 50% only.
Okay, not as good as what the literature report, but I think it's the learning curve also which matters. Same is the case with us. We started very badly, but we are a little better, should I say, compared to where we were when we started. So I think as the time goes by, we get better. Amish, one word on insurance before we close. We're running short of time. Next slide, please. Amish, insurance. How do you?
Insurance. Okay.
Yeah.
Insurance do not pay for scalp cooling.
Correct.
The not very smart insurances, they get the approval under the garb of chemotherapy. But the smart insurance companies with smart doctors sitting there, they refuse to pay for that. There are few patients who have refused to pay for scalp cooling, saying that we might as well lose hair rather than pay for money. But majority of people end up paying money. I have recovered the cost of my machine long back. Whatever I had invested in the machine, and now I'm very happy with the use of the machine. But yes, insurance do not.
Insurance is a problem. Very good. Are there any other questions that anybody wants to ask? Kalpesh, are there any questions that you have which you want any one of the panel members to answer?
Can I actually ask a question? I have a question. Dr.
Please, go ahead once.
What are the most common chemo regimens that people are using the scalp cooling device for? I'm not talking about diseases, but...
Amish, you want to take that?
Yeah, so I'll tell you, Mansi, I failed miserably with 3 days of chemotherapy in solid tumor. There was one young 19-year-old girl, rhabdomyosarcoma, hyphoscytopocide. Whole day we kept the scalp cooling machine on, 97 to 100% hair loss. The second incidence also was same. So multi-day chemotherapy is out. Docetaxel in the standard dose of, if you are using 100 milligram per meter square, it does not work at all. Does not work at all. Yeah. So if you're using 75, docetaxel, in my experience, say 2 out of 5 patients had retained 30% of hair. Remaining 3 had 90% of hair. Where all I have used in breast, AC, paclitaxel, paclicarbo, weekly docetaxel in prostate cancer, in NHL, in CHOP, in colon folfiri, eribulin. Like these are the offhand I can think of.
Okay.
Very good. So if there are no more questions, Amish, the last slide is for you and me. Amish, the one on the left is for me and the one on the right is for you, I suppose. Right. Good.
Let me see.
All right. Thanks so much. Thanks. Because I'm sure I'll end up with the left very soon, and you are the one who's got the body, so the right one is for you. All right. Thanks so much. I will hand it over back to Dr. Pavithran, who is the chairperson. Thank you, sir.
Yeah, thank you all. And I invite Dr. Julka for the expert comments.
Hello. Let me congratulate everyone for an excellent exposition of the scalp cooling. We all know that chemotherapy-induced alopecia is really a distressing symptom for all the women, and especially those who are working women. We have had teachers, we have had, doctors themselves who have asked for scalp cooling, but unfortunately, at Max Lajpat Nagar, we have only one machine and we cannot offer to all of them. So we have to do away with it. But we have also learned that this causes vasoconstriction and less chemotherapy goes to the hair, scalp. So, but still there is no evidence of metastasis in the scalp. So this is another good thing which is there. And we have seen that the side effects are pretty less. They are in the form of headache, which is in less number of cases. And we have not come across many cases where headache has persisted. So I think this is a very good device which we should all use in solid tumors, especially breast. We have used the maximum. And here we see that, hello.
I think we have lost.
Yeah. So we have used maximum in the breast, and in ovarian cancer also we have used. And she's a lecturer in Delhi University, and she maintained her hair. Nobody could say that she had cancer. She used to take lectures fully, completely unknown that she has cancer or not. So people didn't know. She used to take full lectures, and the whole day she used to teach in Delhi University. So that is what, there are certain anecdotal cases where there is 0%, as Dr. Amish told, that in the Nangia series it is 5 cases reported, but we have more than 5 cases who have 0%, no hair loss at all. So I think with scalp cooling, it is a learning curve. As we go forward, we do more cases, as Amish has done. So I think we will, and Jyoti has done. So we will be able to tell more about our cases and collate the data of 50 patients at least, where we can publish the data in our own series. Thank you very much for giving me the time.
Thank you, sir. Now I request Richard for the concluding remarks.
Thank you very much. I just want to say a big thank you to the speakers, to the chairperson, and to all the panelists. I think it was excellent from a presentation perspective, and I like the mixture of sort of real world data and that real patient experience, but also then the supporting clinical data, which are really important to ensure we start getting scalp cooling as a standard of care across not only India, but throughout many parts of the world. It's been incredibly engaging. The panel discussion was fantastic. So thank you all again. And if there's anything that we can do here at Paxman for any of you or any of the attendees that are watching this today, please do reach out to myself, or alternatively Access Devices, who support our customers incredibly well in India. So thank you all. Stay safe, stay well, and look forward to seeing you all in India soon.
Thank you. Bye-bye.